Yeah, sure. Very good evening to all the esteemed faculty, the delegates who have joined us, and DI head office delegates will be joining us soon. So I take this opportunity on behalf of DIOH and welcome you all to the second webinar of DIOH. Diabetes, we all know, is a rampant condition and it is going to be affecting the body from head to toe, I would say. So in that context, we are today understanding the fact that the things are going a little beyond the oral cavity also, and within the oral cavity, we are aware of the gum disease. So we are trying to extend the spectrum of the complications into different other components of the oral cavity. So the broader perspective, Dr. Sumedha Bansal, which will be joining soon, will be giving. She is the scientific team lead of DIOH. She'll be sharing a little more on the concepts behind why did we devise this particular webinar. And before we get started, I would take this opportunity to welcome the esteemed faculty, Dr. Anuj Maheshwari sir, Dr. T.V. Narayan sir, Dr. Balaji, who has gracefully accepted our invitation to be a part of the speakers. Alongside, we are also welcoming our chairpersons for the evening, Dr. Amar Putana. She is joining us from United Kingdom. Dr. Anurag Satpathy, Dr. Purnima ma'am, and Dr. Ramakumar. Thank you all so very much for joining for this webinar. And over to you, Dr. Sumedha Bansal, for the needful.
Thank you. Thank you so much. Ma'am, am I audible?
You're audible. So before we invite her, Anand Kishore, can you please share her introduction slide? So I take this privilege to present before you Dr. Sumedha Bansal. She's a senior consultant in Department of Dentistry, Accord Hospital, Faridabad, and it's also having a private practice at Faridabad. She's the co-chairperson of Diabetes India Oral Health Group. She did her master's in periodontology from Pandit B.D. Sharma University, Rohtak. She's an ex-professor from Sudha Rastogi Dental College, Faridabad, with an over 15 years of experience in academics and clinical practice. She has got numerous publications to her credit, her area of interest primarily being periodontitis and diabetes, and periodontitis and preterm low birth weight. She was the scientific chairman of the first National Symposium of ISP RSDI initiative in the year 2019, as well as the scientific chairperson for the DIOH first National Symposium that we convened in the month of December 2024. So we cordially welcome Dr. Sumedha Bansal. Kindly share your insight on the webinar.
Thank you. Thank you so much, ma'am. Thank you for the kind introduction. A very good evening to everybody. And on behalf of DIOH, I would like to welcome you all, the office bearers, faculty, and delegates for today's webinar, which is named Diagnosing and Managing Oral Complications of Diabetes. So we are always striving hard to get clinically relevant topics so that our clinician friends, they are benefited from all these discussions. Even the researchers, they should be benefited from these discussions. So we have a very good lineup of speakers today, and these speakers are not only experts in their fields. In fact, they're rather very good communicators also. So I think without any further delay, I would like to go back to Sangeeta ma'am so that she can introduce the first speaker of the day today. Thank you so much. Over to you, ma'am.
Thank you, Dr. Sumedha. So basically, we will share a piece of information. Dr. Subramaniam is unable to join today because of some medical reasons. So we have a lineup of the remaining three speakers. Dr. T.V. Narayan, we must thank him because he has graciously accepted his, apart from his topic, he's going to be covering Dr. Subramaniam's topic also. So it's going to be a little comprehensive lecture of his, which is going to be the tail end of the webinar. So we welcome Dr. Amit Gupta. He has just joined. A very good evening, Dr. Amit.
Hello, Dr. Sangeeta. Good evening. How are you?
Very fine. Dr. Amit Gupta is the Joint Secretary of Diabetes India. We welcome you, sir.
Well, thank you, ma'am. Good evening, Anu sir.
Hi, good evening, Amit.
Dr. Amar, Balaji, Dr. Ima.
Good evening, sir.
Everyone.
So a few words from your end, Dr. Amit, would you like to share?
So I can just say that this group is doing amazing work. This is one of the most active group of Diabetes India, and they're doing a lot of work in the field of diabetes and oral health. And Dr. Sangeeta keeps pushing us, and even we are slower to respond, but there is no lack of energy in Dr. Sangeeta. So I wish good luck to all of you, and I'm sure with the expertise of Dr. Anuj and international faculty, Dr. Amar, Dr. Dominica, everyone, we will have a very wonderful webinar. Thank you very much.
Thank you,
Dr.
Dr.
Sangeeta keep pushing RSSDI also.
Really? Really? So good now. If a bit of a push and a tug is required to achieve some goals.
She directly brings the head of the RSSDI back and
so it's an honor to have you, sir,
make that as a speaker in the program, so everything is being endorsed by the RSSDI.
No, it's a proud privilege, sir. You accepted the invitations. We are humbled to have you here, sir. So without taking much ado, allow us to share a brief audio visual for DIOH. Anand Kishore, please play kar dein. Just a compilation of what is DI and DIOH for all the new delegates that you have joined. So there we are as a brief insight about what we have been doing it and we strive to do it. Dr. Bansi, sir, good evening, sir. How are you?
Very good evening. So happy to see all of you.
Absolutely, evening, sir. Can we request all the faculty to kindly put on their videos, please?
So we can have one photo.
Good evening, Dr. Bansi.
Good evening, Anuj.
Dr. Bansi, sir, is the Secretary of Diabetes India, and it's August presence. We are trying to, webcast this webinar. So a few words from your end, Dr. Bansi, sir.
Yes. So first of all, many thanks. Thanks to you, Sangeeta, and thanks to Amit. Amit for reminding me to join. And Sangeeta for wonderful work which you are doing, really. Actually, since yesterday I was a bit disturbed, so I could not join, I could not follow also. And staying patient. So It's wonderful, that we are doing a lot of activities in the Diabetes India, and this oral interest group, Diabetes India and Oral Health Interest Group, is really very active. Only thing is that we are not getting many physicians and the doctors who are practicing diabetes to join this meeting on very regular basis. It's what is more important is that the physician, they should know the importance of this. I am saying Amar, so that I'm sure that in UK, they must be doing a lot of activities just to make people to aware. No, not much.
It's
I mean,
I was going to talk about it in the introduction, what's going on with it, yes.
Dental health is really very poor for our Indian patients, and many of them, they chew tobacco and masala. And since last 15 years, I have a dental chair in my clinic, and there's a full-time dentist who is there. And each and every patient, we request them to see a dentist. Irrespective of, we don't charge for simple one consultation that they have to show, unless there is some procedure or something else which we have to do, and it's at least we do it mandatory once in a year. Why we don't charge that? Many times patient feel that doctors is sending me to see dentist just because they want to charge, and then we explain. But to our surprise, almost every alternate month we get one person with carcinoma which is detected in our clinic, almost every alternate month. So you can understand that how many patients which we are seeing, and most of them are tobacco chewer or smokers. And I have in Gujarat the population with very high incidence of oral cancer. At the same time, they chew tobacco and masala. That's very, very high. And I'm sure this is across country. The second big problem is that diabetic patient, they don't understand the importance of oral health unless you teach. So a doctor or physician, he can't do so many things because he has to teach for eye health, for foot care, for oral health, and then for vaccination, and then for multiple things along with our diabetes, the core things like for lipids, for sugar, for self-monitoring, for hypoglycemia, for so many, and for insulin and then insulin technique. So you need actually a team, a supportive system where each and every aspect of the thing is done. So I do in my clinic, there is a checklist for the patient that everything is being done from A to Z, like maybe body mass index, and we do BCA and then dietitian take consultation, everything. So that comprehensive care, I think, is required. And one of the very important area which is completely neglected in our country is oral health. And it is not, I mean, in private setup, even in a public hospital or a big hospital or a big institute, where the Department of Endocrinology or Diabetology or even they sit, because it's a completely oral health or dental department is altogether different building, or a in my medical school, actually, there was a medical school and there is a dental school. So they're two almost 1 kilometer away. You can't send the patient, even he can walk. He has to take the car or taxi. Anuj had worked in dental hospital. He was professor of head of Department of Medicine in Dental Medical College, but now I think he left and now he joined medical college. So his experience will be again very useful. And currently he's our RSDA president-elect. But I feel whether it's a RSSDI, Diabetes India, Physician Association, Endocrine Society, if everyone start talking in India about the oral health, it's an important neglected area in diabetes management. I'm sure in coming years, we will have more number of people who are regularly getting checked up by dentists. The second thing is the dentist also should start talking more about the importance of oral health and overall dental care in persons with diabetes. So they should also do a lot of public awareness activities at the same time. And again, I request Amit, he is very active, that if we can involve more physicians in this webinar, it will be great. But now he had become IDF school chair, so I'm sure we will have a dedicated module on diabetes and oral health. He can create some program where diabetologists and specialists like dentist and oral health specialists, they all can work together. They can create a module. I don't know whether we can do some sort of a certification or not, But if it goes to thousands of physicians and doctors, or even rather more than that, I'm sure there will be improvement. So once again, Sangeeta, you are really wonderful. You do a lot of activities and we all praise you. Congratulations from Diabetes.
Thank you. It's a teamwork, sir. But yeah, we take a opportunity to take your blessings. Dr. Anuj, sir, quickly, for 2 minutes, quickly, we'll have a word
But
from
before I end,
you.
I want to say that, the Dominica, our dentist, our close associate of Diabetes India, and we were there in WhatsApp before some time. And she's a wonderful host. We really enjoyed. So I just want to inform everyone. And thank you, Dominica. We really enjoyed it. Thank you. Thank you.
My pleasure.
Great. Dr.
Now,
Anuj,
what
sir,
Anuj? Sorry.
can we have 2 words before we start the webinar from
Yes,
your
sir.
end?
Yes. So before I start, I think I must pass on my condolences and prayers for those who have lost their life in their plane crash in Ahmedabad, outside of the plane, inside of the plane. That really has been a very tragic to all of us. In fact, this oral health has been very close to my heart since from the very beginning, because as Dr. Bansi has already said, I have worked with the dental college and dentist for a long time. So even in 2006, when ADA has declared it as a sixth complication of diabetes, this periodontitis as a sixth complication of the diabetes. At that time, I was really looking for to find someone like Dr. Sangeeta Dheer to start and to mobilize the dentist and oral health practitioners for the diabetes care, so that they may be more inclined towards the diabetes, because there is a gap between from the both the sides. Physicians never send their patient for the oral health checkup. At the same time, dentists also not very much bothering about their diabetes. Many of the times they don't ask. Now the things are changing. Now the people have been more knowledgeable about the diabetes. Even many of them are treating also at their own. Even I have taught them when I was in the dental school. I taught them that how to treat the emergencies when the patient is with the diabetes. If you are having any dental emergency and patient is having the hyperglycemia, how to treat that patient and how to make it normal glycemic. I always taught to my dental students that for you more important to use insulin instead of the oral medication, because nobody would come to you for the long time treatment for the diabetes. For that they will always search for the physician, but your role would be there when you are handling any emergency and you need to operate your patient, or your patient is keeping the hyperglycemia. Then you should know that how to handle the insulin, how to use insulin, how to calculate the doses of insulin. So these things has always remained my mind, and that's why whenever it is asked to me to come for the any talk related to the oral health or any related to the periodontology or related to the dentistry, I always remain there, because this is the space which is having a gap and as well as neglected a lot for a long time. So thank you, Dr. Sangeeta Dhi. Thank you, Diabetes India, which has recognized this space to be filled up. Thanks, Dr. Bansi and Dr. Amit Gupta, and would be trying to make this kind of the space in RSSDI also in next 1 year, so that we can have something concrete work and concrete research work on this particular area of the which is not yet have been explored. So that's my idea, and for that I really look forward to help from all of you, all the international as well as national faculties of the dentistry. And I really wish that more physicians should be involved here, because I can see here, except me, nobody is a physician except me and Ram Kumar. Of course, Dr. Bansi Sabu and Dr. Amit Gupta is from the Diabetes India, but they are not in the speaker list today. And today's faculty, only me and Dr. Ram Kumar is the only two physicians. Rest all are the oral health experts or from the field of the dentistry. So would be very happy. Yes.
Dr. Amir is there.
Yeah, Amar is there. So would be
I would add to that.
very happy if more physicians from India should take interest in this faculty of dentistry for the diabetes management, to find their complications which is coming in the way of the diabetes management, and bi-directional issues which are arising out of the diabetes towards the dentistry. And because of the periodontal problem, the diabetes is getting out of the order. So looking forward for that. Thank you very much, Dr. Sangeeta, for giving me this opportunity. Thank you, Diabetes India, for inviting me.
Thank you so much, sir, for your...
Dr. Anuji, I married a dentist. I am so interested also.
Great. So with that, very interesting discussions, we take this opportunity to get kick-started with the webinar. And we'll be starting with the first lecture of the evening. Nankishore, can we have the introduction for Dr. Amar Putana, please? So Dr. Amar Putana, he is the first chairperson for the lecture. He's MB and CHP and MRCP, Diabetes and Endocrinology. He's a consultant in the West Midlands and honorary senior lecturer at the University of Bangor. He has won teaching awards from the University of Birmingham and Royal College of Physicians of Edinburgh. He has served as distinguished service and endocrine specialist for the MRCP Part 1 examining board. He has received excellence in Patient Care Award from the Royal College of Physicians for contribution to the profession and won a Quality in Care Award for his work in diabetes and dementia. He has been involved with national and international organizations such as the British Medical Journal and the European Association for the Study of Diabetes on the e-learning platforms and his own education Google platform, Google Docs. He's a speaker at national and international conferences and publishes regularly in reputable journals and creates various guidelines. He is also a part of an education course in oral health and diabetes at the University of Birmingham and is a co-creator of the website periodiabetes.org. With these few words, Dr. Amar Putana, we welcome you, sir, for this session.
Thank you. Thank you very much. It's a pleasure to be here. And I know Bunshi was mentioning the differences between, he thinks the UK is doing a lot better.
Recording in progress.
But in honesty, there is still this bidirectional deficit, I would say, in diabetes physicians and dentists as well in the UK. And in fact, the dentists are probably doing more, as you see with the speaker panel here. The dentists are doing more in the UK they understand the more systemic impact of periodontitis and diabetes impact, whereas the physicians in the diabetes are still trying to learn that and develop that more, even if the guidelines have improved in the UK. And the NICE guidelines say, look at oral health. The practical aspect, there's a gap, there's a knowledge gap, but also there's a practical practice gap. And only by increasing the knowledge gap, reducing the knowledge gap, can we reduce the practicing gap. And this is why for the last 7-8 years, I've been trying to improve that awareness, and seeing what Diabetes India are doing. You're probably one of the most active, one of the most clued on into this area compared to even what we have here, even though we know about this. And so I commend you all for this, and it's a pleasure to be chair and to be part of this.
Thank you so much, Dr. Amar, sharing your experience. Nankishore, please share Dr. Anuj Maheshwari's introduction slide, please. Dr. Amar, kindly introduce the speaker, please.
It's my pleasure to introduce Dr. Anuj Maheshwari, who's a professor in Department of Medicine, Hind Institute of Medical Sciences, Lucknow. He's president of the Asian Pacific Society of Hypertension and president-elect of RSSDI shortly. Secretary General of Indian Society of Hypertension as well. He has published numerously in a number of different international and national journals, as multiple publications in diabetes, hypertension, and its complications, and has received numerous awards from the R.J. Wegman Oration through to the Hazra Oration, and many notable achievements, such as the 2016 Notable Achievement Award. There's so many things. He's getting embarrassed by me talking about everything he's done. But he's done a lot, he's doing a lot, and now he's going to talk to us about the pathogenic mechanisms of diabetic complications. And we look forward to your talk, Anuj.
Thank you. Thank you, Amar. And can I share my slides?
Yes, please.
Yes. Hope my slides are visible to you.
Yes, sir.
Yes. So that's great. So in next 15 minutes, I shall be talking about the topic which I have been given and requested by Dr. Sangeeta to speak upon that pathological mechanisms of oral complications in type 2 diabetes. As we all know that diabetes affects the multiple systems, including the oral cavity also, including the whole dentistry, but it is very less discussed complication of the diabetes. So if we talk about the diabetes and oral health, it is a clinical two-way connection. Diabetes alters the balance of the microorganism in mouth that weakens the body's defense system, making it harder to fend off oral infection. On the other hand, the infections which are occurring in the oral cavity can cause the blood glucose level to spike, making it harder to control diabetes. Poor oral health can further increase the risk, and inflamed gums can lead to systemic inflammation. That's why periodontitis has been declared by the ADA as the sixth complication of the diabetes. Oral complications in the diabetes, if we talk about, it's xerostomia is one of the most common thing what patient complains. Sometimes it is induced by diabetes, sometimes it is induced by the medications which are being given for various reasons in the diabetes. Dental caries, oral candidiasis, periodontal disease, burning mouth syndrome, delayed wound healing, and trigeminal neuralgia. So pathophysiological framework behind all these problems is obviously remained with the hyperglycemia, which is elevated blood glucose triggering multiple cascades leading to the infections, leading to the ab- uh, abnormal control, leading to the uh, difficult control for the infection with immune dysfunction, which is having a compromised immune response to oral pathogens. Insulin resistance is another important factor, which not only gives rise to the hyperglycemia, but also it is responsible for deficiency in the immune system, which is brought through the increased free fatty acids and dyslipidemia in the cellular level. Hypertension, dyslipidemia, all these things are the adjunct to the problem which is supporting in the pathophysiology leading to the harm in overall oral cavity. Central mechanism is hyperglycemia. The sustained hyperglycemia, when the blood glucose level always remains high, HbA1c is never being met 6.5 or less than that. In such situations, certain biochemical pathways gets activated, which damages the cellular mechanism in the body. And what is those tissues which are damaged because of these biochemical pathways? Because a lot of inflammation and a lot of inflammatory markers are being risen in the blood vessels and blood circulation, ending up with the oral manifestations, development of the various oral complications as a result of that. So if we talk about the immune dysfunction, this is reduced function of the neutrophils, macrophages, and T cells, which are supposed to be acting as a defense body of the defense of our body. They bring the chronic inflammation at the fore. Persistent inflammatory state damages the tissue, and finally, it makes more susceptible for the opportunistic infection. So when we talk about the periodontal disease, the sixth complication of the diabetes having the 30 to 50% prevalence. It's adult with some form of the periodontitis suffering with that. 9 to 11% are the severe cases with severe periodontitis, and two times having the diabetes risk in, especially when the diabetes is the poorly controlled. So pathogenesis behind the periodontitis and periodontal disease, again, the inflammation plays an important role. It damages the tissues. Bacterial accumulation triggers the inflammation again, and this phenomena is complementing each other. Inflammation allows the bacteria to grow more and more. It provides the surface for the bacteria to be staying there, and at the same time, once the bacteria grow, it increases the inflammation, ending up with the tissue destruction, loss of gingival tissue, loss of bone and periodontal ligament. Ultimately, it leads to the loosening of the tooth, as well as tooth mobility is lost. Diabetes when it is combined with the periodontal disease, or if we wish to connect the periodontal disease directly with the diabetes, of course, hyperglycemia, which is associated with the advanced glycemic end products, once they are accumulated, they causes the damage to the gingival connective tissue. And once they go further, it damages the bone tissues also. Immune dysfunction again ends up with the destruction of the tissues through the inflammatory response, and vascular damage impairs the tissue healing and defense mechanism. If we look for the caries in the oral cavity and the risk factors in the diabetes, it is because of more reduced salivary flow, which decreases which has the decreased buffering capacity and protective function of the saliva is lost because of this. Elevated level of the salivary glucose provides nutrition for the bacteria which can lead to the caries. Oral microbiome is altered. It increases the counts of the karyogenic bacteria like streptococci and lactobacilli. Lower calcium and phosphate levels in saliva affects the remineralization. So finally, we saw a lot of patients who having the diabetes, they complain about the dry mouth. It is because of the hypersalivation, and this xerostomia is sometimes because of the subjective sensation which may occur with or without actual reduction in the salivary flow, and significant higher prevalence in diabetes with multiple studies confirming reduced salivary flow rate. But at the same time, neuropathy also plays a role in causing this. Mechanisms of the dry mouth in diabetes, of course, polyuria and dehydration are important reason. Whenever we have the high level of the glucose or hyperglycemia, this ends up with the polyuria, and once more glucose is passing through the urine, it attracts it with lot of water, and patient undergoes in the dehydration. Then lot of fluid loss happens there. Dry mouth is obvious to occur. Neuropathy, as I already said, autonomic nervous system dysfunction affects the salivary gland innervation. Salivary gland changes like structural alterations, including acinar vacuolization and atrophy of the salivary gland, which reduces or hampers the formation of the saliva and flow. And some of the medications which are used in the treatment of the diabetes as well as in the treatments of the diabetic neuropathy, they have the side effects or adverse effects of the dry mouth, or sometimes once they are combined with the reduced saliva, their impact becomes more and patient becomes in trouble situation. If we talk about the impact of the dry mouth, of course, this dry mouth leads to more caries in the body, in more caries in the oral cavity because of the reduced protective effects of the saliva. Oral discomfort in the form of the pain, burning sensation, difficulty in speaking, eating difficulties like problems arising with the chewing, swallowing, and tasting. It also has its impact on the taste buds. More of the infection risk with greater susceptibility to the oral candidiasis. The oral mucosal lesions arising out of the candidiasis, like fungal infection, more prevalent in diabetes. Median rhomboid glossitis, which can be looked like this, where the formal of the candidal infection with characteristic tongue appearance may be there. Angular cheilitis, the inflammation at the mouth corners, which is very commonly seen in children, even without diabetes also, those who are consuming lot of sweets and lot of sugary products, often candida related in diabetes patient. Candida infections and it's a pathogenesis which is working behind. Of course, the immune response impairment plays an important role, but at the same time, enhanced addition of the candida to the oral epithelial cells in diabetes patient has been seen. Reduced saliva flow because of the diminished mechanical washing and antifungal components. High level of the glucose again provide nutrition to the fungal elements, candida species, and which again improves their growth in the oral cavity. It is also connected well with the oral cancers. Diabetes patients are more prone to develop the oral cancers. Meta-analysis had shown increased risk in patients with diabetes. Advanced glycemic end products and their involvement increased in the cancer cell migration and survival through the RAGE activation. Prognosis remains the poor if the diabetes is not well controlled, especially the overall survival of the cancer patients remains poor in the setting of the diabetes. Hypertriglyceridemia associated with the high risk of the oral pre-malignancies commonly seen. Taste disturbance. The mechanism involves the neuropathy, microvascular damage, taste bud changes because of the increased cell apoptosis in taste buds and decreased innervation observed in animal models, xerostomia like dry mouth after dissolution and transport of the taste molecule, burning mouth syndrome, clinical presentations in burning, scalding, tingling, or numb sensation in the mouth without visible lesions. Neuropathy always remains behind the occurrence of these symptoms. Common sites are the tongue, lips, palate, and other oral mucosal surfaces. Other accompanied by xerostomia, dysgeusia, and other sensory disorders. So overall diabetes impacts on the implant success is again very detrimental. Diabetes doesn't allow the implants to be successful. 15 to 28% peri-implantitis is seen in the patient with diabetes. 50% has got the increased risk with hyperglycemia, and 3 times relative risk is there for patient with diabetes at implant placement for losing the implant. So you look for the prevention strategies. Of course, the oral hygiene is one of the important things which must be emphasized not only by the dental practitioners but all the diabetologists. All the diabetologists, all the physicians, those who are treating diabetes must ask their patient to go for the oral examination, look for their oral cavity, regular monitoring, reinforcement techniques for improvement in the oral hygiene. Frequent professional care, they must visit the dental practitioner at least every 3 to 4 months. Regular professional cleaning to prevent the periodontal deterioration. Specialized intervention, the form of the salivary substitutes for the serostomia is required. Fluoride application prevents the caries. Antimicrobial strategies could be utilized. Lifestyle optimization is again important whenever we talk about the diabetes, dietary counseling for oral and systemic health, smoking cessation, glycemic control, and less use of the alcohol is important issues to be implemented. So if we talk about the rainbow model of the integrated care, so whenever we talk about the oral cavity, it is really requiring the integrated care, that integrated care between the system, organization, profession, and clinical. So if we talk about the clinical integration, this could be the joining hands with the diabetologists and dentists and practitioners, or especially the periodontologists together, so that we can not only control the patient's diabetes better, but also can save them from very dreaded outcomes of the oral cavity problems like oral cancers and xerostomia kind of the things. So concluding the talk, united for the better outcomes. A healthcare professional, as healthcare professionals, we all hold the power to not only treat disease, but transform lives. When diabetologists and dentists unite, we can address not just symptoms, but the root causes, giving our patient the opportunity to live healthier, fuller lives. Let us commit to breaking down silos, sharing knowledge, and building a future where diabetes care includes oral health as a standard practice. Together, we can change the narrative one patient at a time. Thank you very much for your kind listening.
Thank you, Dr. Anuj, for that comprehensive lecture. It was truly, amazing to hear the details that you have pointed out. So we come to the conclusion of the first session. Thank you, Dr. Amar, for chairing the session. And now I would like to invite Dr. Sumedha to open the next lecture session, please. Over to you, Dr. Sumedha. Dr. Sumedha. Dr. Sumedha, please unmute. Yeah.
Yes.
Yeah, please introduce the next session, please.
Just a second.
डॉक्टर नंद किशोर जी, डॉक्टर राम कुमार का स्लाइड शेयर करें. Over to Dr. Sumedha.
Now we'll be moving on to our next lecture, which will be complications related to the teeth, its supporting structures, and peri-implant diseases. And I'll be introducing the chairperson for this session, and he is Dr. V.V. Ramakumar. He has 30 years of experience. He's a diabetologist, gelatologist at SVR Diabetes Care and Research Center, Guntur, Andhra Pradesh. He is Mary Jane Mize Scholar, IDF 1998. He has received his training at Jocelyn, USA, Karolinska, Sweden, Steno, Denmark. He's past president, APDF twice, faculty RSSDI, Diabetes India, 3DCon, APDF, DFSI, certified trainer for diabetes education, certified laughter yoga leader, promoter of laughter therapy in various national and international conferences, and he is also the founder of Smile Diabetes and Research Trust. Thank you, sir. Over to you.
Thank you very much for giving me this opportunity to be with you all. And I thank Diabetes India and the Special Interest Group. I will be chairing a session which is rather new because many people are getting their implants, and implantitis, that is inflammation of the implant, we will be talking. And if you know, the complications related to teeth and implants primarily involve inflammatory conditions and infections that can damage the supporting tissues and potentially lead to tooth or implant loss. Proper oral hygiene, addressing the risk factors and diabetes control as a diabetologist is most important. Recently, we had a patient, my wife did implants for whole teeth, and he's doing fine. Okay, I invite the speaker. And
please share Dr. Balaji's introduction slide, please. Over to you, Dr. Ramkumar. Kindly introduce the speaker.
Yeah, and it's my pleasure to invite Dr. Balaji Manohar and introduce him. He's an alumnus of A.P. Shetty Memorial Institute, Bangalore. He's a fellow faculty of dental surgery at Royal College, Glasgow and Edinburgh. He also has a master's degree in hospital administration. That's wonderful. He has a teaching experience of over 25 years and has several accolades to his name, like the A.V. Vasantarao Award, Dr. I.R. Goyal Award, and Most Proactive Senior Academician Award, to name a few. You will see him in the forefront of several researches and publications and guiding postgraduate students as well as PhD scholars from 2006 onwards. He has extensive organizational experience and honorary secretary of the Indian Society of Periodontology. He has been the part of Indian Dental Association as the honorary secretary of the Udaipur branch at the joint secretary of Rajasthan State branch. He also won runner-up award as the editor of Rajasthan State Dental Journal of the Year 2014 and 2016 twice. So it's a pleasure to welcome Professor Balaji from Udaipur, the Lake City, right?
Thank you, sir. Thank you, sir. Thank you very much.
Everybody want to visit your place and visit you also.
Most welcome, sir. It will be a pleasure to host you, sir.
Thank you very much.
Right, sir. Can I share my slide?
Yes, please.
Is it visible?
Yeah, please go ahead.
Right. Thank you very much, Ram Kumar sir, for a introduction. And as Anuj sir said, you are the laughing Buddha here, and I can see your smiling face over here as well. And it's a great opportunity. Thank you very much, Diabetes India, for having invited me to speak today on diagnosing and managing oral complications of diabetes. Just a minute, 1 minute. Yeah, that's fine. Okay. Thank you, Dr. Arvind, Dr. Bansi sir, Amit Gupta sir, Dr. Sangeeta, and Dr. Sumida for inviting me to speak today. I feel Dr. Anuj has covered most of the things what I wanted to speak today over here, and it has actually made my work a little simple because Sir has totally dwelled into whatever I wanted to speak. But nevertheless, since the opportunity is given, I will do my part and try to deliver whatever best I can. So I will be dealing basically with the complications related to tooth, its supporting structure, and the peri-implant disease in diabetes. Before we go into the topic per se, let us just have a look at what the World Health Organization in its 60th World Health Assembly in 2007 reported about the Oral Health Action Plan for Promotion and Integrated Disease Prevention. They acknowledge the fact that there is an intrinsic link between the oral health, general health, and quality of life. And they also said that the oral health is a neglected area of global health. It's a huge statement which they have made in 2007. Going on in 2009, one of the leading journals in the medical practice, the Lancet, in their editorial on oral health, prevention is the key, stated that promoting and improving oral health should be part of routine agenda of healthcare policymakers and clinicians. They also went on to say that diabetes is a major risk factor for periodontitis, and this is about three times, threefolds a risk factor for periodontitis. And they said that interaction between the two diseases have an important clinical implication for dental professionals, physicians, and the most importantly, the patients who are suffering from these type of problems. So we all know that periodontal disease is one of the most chronic inflammatory conditions, and 90% of the world population is suffering from one or other type of gingival or periodontal diseases. And out of these, about 5 to 15% of the adults are suffering from severe periodontitis. Now, these problems which are occurring, there is a damage to the tissue which is occurring, the gingival tissues, the periodontal tissues, and it is largely an irreversible type of damage that is happening. And the most important thing why the patients are not taking treatment for this type of problems is periodontal disease is generally seen to be painless. And unlike a pulpal condition where the patient has sharp shooting pain, the patient generally doesn't visit the dentist to get the treatment done. So if we see the potential mechanism which was put forward by Pollock and Shapira in 2018, very recently, to show that whenever there is a case of periodontitis or untreated periodontitis, the bacteria and the bacterial antigen, along with the pro-inflammatory mediators and cytokines, they are seen to be circulating, and there is an increase in the systematic inflammatory state, which causes impairment of insulin signaling, and there is increased insulin resistance, which gives rise to the HbA1c levels to be elevated. Now, and this eventually causes the diabetic complications which we are seeing with the patient. So coming on to the next part, what these conditions or the diabetes, do they have affect the tooth structure, whether they are going to have any effect on the enamel, dentin, and pulp and other structures. Let us just have a quick look at what effect this diabetic situation causes on enamel. Uh, Recently, there was an article which has been put up by Charles et al., who have shown that type 1 diabetes, there is effect on the mineralization process of enamel. And this is because of the reduced calcium and fluoride content, which happens because of the hyperglycemia which is present, which eventually causes the caries. And they also observe that in diabetics, there is an irregular arrangement of hydroxyapatite crystals in the enamel. Now, as the oxidative stress increases because of the hyperglycemia, there is seen to be higher magnesium and lower calcium concentration in enamel, which eventually gives rise to the caries. And along with that, in 2004, there was a animal study which was done by Attar, where they showed that whenever there is in these rodents the diabetes is induced, there is a reduction in the calcium and phosphorus in the enamel structure. And histologically, it was also seen that there is effect on the enamel, which is very detrimental. This group again in 2007 published another article which went on to show that there is enamel hypoplasia whenever there is diabetes introduced in rodents, and there is insufficient calcium concentration which is affected by the presence of hyperglycemia. But on the contrary, in 2019, it has been shown that if we are applying the enamel matrix derivative on the damaged enamel in diabetics, there is enamel regeneration seen. So which was a very positive finding which showed that enamel could be regenerated while applying the EMDs. Now, if we see the effect on dentin, due to the resistance of insulin, there is impaired osteoblastic activity, of course, which is affected by hyperglycemia. There is increased ROS activity, and there is continuous removal or calcium concentration is reduced in the serum, which causes the hypomineralization of the dental tubules. So in this study, which was done by Abbasi et al., they have shown that both enamel and dentin formations were affected. And in the microtomography and micro-CT image analysis, it was seen that the thickness of the tissue, that is the enamel as well as dentin, the tissue thickness was seen to be lesser in the incisors and the molar region. And eventually, the next tissue, the pulp, which is at the center of the tooth, which is covered by dentin from all the sides, it was seen that periodontitis effects induced by the diabetes mellitus, it affects the pulp through the periapical pathway. Now, the pulp and the periodontal ligament are derived from the ectomesenchyme, so there is definitely a connection between the pulp and the periodontal ligament. And this study was, or rather published way back in 1970, which said that there is connection between the periodontitis in diabetes mellitus as well as the pulp. And very recently, sir also spoke about the candida infection in diabetic people. It was seen that the diabetic individuals, there was a high prevalence of candida infection in the pulp chamber also, up to about 79.2% of pulpal infections. There was candida culture which was seen in these cases. And there is pulp and periodontal pocket of the diabetes type 1 individuals have shown high accumulations of the AGEs, which inhibits cell proliferation of collagen, which eventually impairs the wound healing at the inflammatory site, in this case, which is going to be the pulp, which is seen. Now, the surrounding or the supporting tissue of the tooth, if I say that is the cementum, which is covering the dentin in the root surface, and this is the region where the most bacterial infection is taking place because of the pocket formation, which is going to be seen over here. So the cementum is the primary site where the infection would take place, and after the cementum is destroyed, the dentin is the next layer which is going to be destroyed over here. So whenever there is hyperglycemia present, Belgian et al. Have seen that in their study that there is an increased blood glucose level which activates the protein kinase C activity, and there is increase in the production of proteolytic enzyme, and also there is increased collagenase activity which breaks down the collagen in these conditions. But whenever there is activation of the PKC, there is also seen to be there is increase in the secretion of the pro-inflammatory cytokines. There is increase in the vasoconstriction promoting cytokine endothelin, and there is also increase in the vascular endothelial growth factor, which increases the permeability of the bacteria and other microorganisms into the periodontal pocket. So all these things have been reported in 2019. An article which was published in the Journal of Indian Society of Periodontology to evaluate the thickness of cementum of periodontally diseased teeth of non-diabetic to that of the type 2 diabetic showed that there is no significant difference in the thickness of cementum when the diabetics were compared with the non-diabetics. And again, the comparison of thickness of cementum when it was seen in type 2 diabetes by Gorkhan et al., they have seen that the apical and mid of the apical half, the cementum was seen to be thicker, whereas the central part of the root and midpoint of coronal part, it is seen to be thinner. So these are just some findings which say about the thickness of the cemental tissue which has been there. So basically, if we put all this into a nutshell, if we compare a non-diabetic individual's tooth to that of a diabetic individual's tooth structure, we understand that the enamel and dentin is thinner, which is prone for the caries. There is inflamed periodontal pocket. The cementum is involved over there, and there is connection between the periapical of the pulp and the periapical region. There is increased thicker vasculature in the pulp chamber. So this is basically everything what we saw the effects of diabetes mellitus on the tooth structure or the tissues of the tooth, which we saw just now. When seeing about the correlation or the diabetic status and peri-implant diseases, there have been few meta-analysis and systematic reviews which have been published, which have shown that the chronic hyperglycemia is an important risk factor for peri-implant diseases. This is what Dr. Anuj also just now mentioned, that that there is a lot of cases where the diabetic individuals are at risk of peri-implant diseases. And but there have been meta-analysis where diabetics were seen to be significantly at higher risk than the healthy controls. But there are certain literature which have been showing that actually there is no much evidence available to show the significant association between the diabetes and the peri-implantitis. And these articles, if you see, are more recent articles which have been published as compared to the ones which I just mentioned in the previous slide. These have been published in 18, 20, and 20 again. So it brings us to a crossroad as to whether the diabetics are really at the risk of having peri-implant diseases or not. So at this point, it would be what is required is a well-controlled and long-term trials, which will give us good evidence to translate the evidence into having an appropriate management for the implant therapy. So we all know when we are trying to do the treatment for diabetes as well as periodontitis, we know and we have understood in the by Dr. Anuj also that it's a two-way relationship. Diabetes is a risk factor for periodontitis, and people with diabetes are at a higher risk for periodontitis than the people who are healthy. So there have been a lot of studies, systematic reviews, randomized controlled trials, which have been conducted to check the association between these two things. But if you look at literature, there are about 8 systematic reviews and meta-analysis, including 2 Cochrane reviews, which are basically trying to see the efficacy of the periodontal treatment and the glycemic control. And all these studies, if you see, or all these literature reviews, if you are going to see, there is one consistent finding which says that periodontal treatment is associated with reduction in the HbA1c level. British Medical Journal in 2000 also published an article which says the periodontal treatment, when it is done, gives an improvement in the HbA1c level, and it has a very big or significant clinical impact. And it says that every 1% reduction in HbA1c is having a measurably reduced risk for the diabetic complication. So we understood the pathogenic mechanism as how the disease or how the diabetes complications are increasing because of the periodontitis. So if we are doing a periodontal treatment, or the supportive periodontal therapy is being done, non-surgical periodontal therapy is being done, what it does basically is it reduces the bacteria and the bacterial antigen. There is reduction in the inflammatory mediators, the cytokine reduction. So eventually there is a reduction in the systemic inflammatory state, which improves the insulin signaling and reduces the insulin resistance, thereby reducing the HbA1c level, which improves the diabetic status, and thereby reducing the diabetic complications. So the non-surgical periodontal therapy is a very effective treatment for bringing down the diabetic status of the patient also. Not only is it important for us to do the professional treatment, but it is also important to teach the patient about maintenance or the plaque control, which is very important, because this plaque is the one which is causing the inflammation over there and causing the periodontal destruction. So it's very important that plaque control is being done, or meticulously being done, by the patient, apart from the treatment that the professional is delivering to the patient. So there have been certain guidelines and recommendations that have been given regarding the management of periodontitis and diabetes, various associations, including the International Diabetic Forum in 2009, which gave the guideline on oral health for people with diabetes, where they told or requested the medical professionals to, advise their patients to seek dental or rather see a dentist regularly. And then even the European Federation of Periodontology, along with the American Academy of Periodontology, they have given certain consensus and manifestos on periodontitis and general health, where they ask the medical professionals to inform their patients regarding the link, or rather the link between periodontitis and diabetes, and expect their patients, diabetic patients, to visit the dentist regularly, and also, take the periodontal monitoring, and take the or undergo the periodontal treatment, so that their diabetic status can be improved. And Dr. Amar is also here. He was speaking about the medical professionals not taking much charge of the condition. For him to know that the British Society of Periodontology also in 2016 gave a good practices guide to periodontology, and it asked the dental professionals to inform their patient about the link and liaison with the medical doctor to get the HbA1c levels checked. And again, in 2017 also, they had a campaign where they have informed the patients about the diabetic links. And recently, I would not say recently, but in 2018, a joint consensus report was published by the European Federation of Periodontology, as well as the International Diabetic Forum. It was a scientific evidence on the links between periodontal disease and diabetes, which appeared in both the journals. And not far behind is in the Indian scenario also. Anuj sir is there. The RSSDI, along with the Indian Society of Periodontology, in 2020 published a joint statement regarding the management of periodontal disease in patients with diabetes, which was a good clinical practice guideline. And this guideline basically informed or recommended that the non-surgical periodontal therapy is not a contraindication at all in diabetic patients. And surgical periodontal therapy, if it is to be done in diabetic patients, the HbA1c level, if it is between 6 to 8, we could do a surgical periodontal therapy for the patient as well. And whenever or if the patient's level is greater than 8, the supportive periodontal therapy has to be done, and the patient should be kept on a recall visit every couple of months with home care. And there is, if it is greater than 8, definitely there is need for medical professionals intervention, which is advisable. And whenever the dental treatment is being performed for the patient, before the treatment is being done, it is advisable to use 0.2% chlorhexidine for 1 minute as a pre-procedural rinse to reduce the microbial burden. And use of the prophylactic antibiotic to prevent bacteremia is not advocated in these guidelines. Adjuvant antibiotics also is not recommended if the patient is fit to undergo treatment. And whenever we see diabetic patients, many of them come with the presence of periodontal abscess in their oral cavity, or gingival abscess, or abscess in any other place. So the initial treatment for these type of patients is drainage and debridement. And the systemic antibiotics may be prescribed based on the systemic condition or the local condition of the patient. And dental implants and periodontal procedure, regenerative procedures, where we might be using some techniques to regenerate the lost bone, are treatment which can be done in well-controlled diabetic patients. And similarly, and awareness is what is very important. Again, as Anuj sir told just now about more of medical practitioners being involved in the awareness program. First thing is the awareness for the patient. So it is very heartening to see that the Diabetes India Oral Health Group also has patient information pamphlets which have been made for educating the patient regarding their oral and periodontal condition. A diabetic patient who are made supposed to be aware of their oral and periodontal health, so that if the periodontal intervention is done, the patient's general condition can be improved. Similarly, not only the patient, the medical professionals also need to be educated regarding the link between periodontitis and diabetes, and the potential benefit which the periodontal treatment is going to give. And they should urge their patients, diabetic patients, to go in and get their dental examination done, and if any treatment is required to be done. So the recommendations regarding the oral health care for the oral healthcare team is to have a routine periodontal assessment for all the patients, including the diabetic patients, and assess their glycemic level and glycemic control. And if they are healthy periodontally, a long-term preventive care and monitoring should be initiated for them. And diabetes should also be evaluated, and other potential oral complications, like sir mentioned just now about various other problems which might occur in the oral cavity because of the presence of diabetes, needs to be looked into and treated as well. So thank you very much for giving me an opportunity to be here today. I thank everyone from the DI team as well as RSS DI team for giving me this opportunity to be here with you all.
Thank you, Dr. Balaji, for explaining very nicely about the pulp, enamel, cement. And you also assured us that if you control glycemia properly, implants are not a problem. We have to tell the patients it weighs both ways. for proper glucose control, oral cavity should be clean. And if you can clean, you will prevent complications also. Because I remember there was a study which said that gum leads to heart breaks, and because it affects the heart also. So we had to tell them. I teach my patients every day, go and check, but they don't bother. My wife is safe only. And I must thank Dr. Sangeeta and Dr. Balaji for giving a good lecture. And I want to give you an award. You know what a dentist gets as an award usually? In Dr. Balaji, can you tell me? A little plate. A little plate. Can you? Thank you very much.
Thank you, sir. Thank you, sir.
Right. Thank you, ma'am.
Thank you so much, Balaji, sir, for
Thank you,
this
ma'am.
exhaustive lecture.
Thank
Sir,
you.
it was indeed very good because right from you told us everything, right from the history, the research that has been done in this, and oral complications in diabetes, and how do they happen, and how can we manage them. And
Yes.
of course, about the awareness part also, so that the dentists and the physicians can equally make their patients aware about both the diseases and the relationships. Thank you so much, sir.
Thank you, ma'am. Thank you so much. Thank you very much.
Thank you for the second session hosting Dr. Sumedha. Now we come to the last lecture for the evening, which will be taken up by Dr. T.V. Narayan. And this comprehensive lecture will be chaired by two chairpersons. May I invite Dr. Purnima Nadkarni? Can I have her introductory slide, please? Nankishore? Okay, Dr. Purnima Nadkarni, ma'am, she's a professor in the Department of Periodontology, the Swani Dental College and Research Center, Kota, Rajasthan. She did her BDS from Goa Dental College and Hospital, 1999 batch, and an MDS from Government Dental College, Goa, 2004. She has been into academics since 2004 and has served as professor and head of the department at the New Horizon Dental College and Research Institute, Bilaspur, Chhattisgarh. She has authored and co-authored several national and international publications. She is very active in conducting oral hygiene awareness and dental camps and community service. I invite Dr. Sumedha Bansal to introduce the chairperson as well, Dr. Anurag Satpathy. Could I have Dr. Anurag's slide, please? Kishore.
It's a pleasure to introduce Dr. Anurag Satpathy. He's Professor, Department of Periodontology, Institute of Dental Sciences, Shiksha Anusandhan University, Bhubaneswar, Odisha. He is Diabetes India Oral Health Group Executive Committee member. He graduated from Bharati Vidyapeeth Dental College and Hospital, Pune, Maharashtra in 2001 and did his post-graduation from SDM College of Dental Sciences and Hospital, Dharwad, Karnataka. He is an ardent researcher and speaker with research interest in tissue regeneration, biomaterials, periodontal medicine, peri-implant disease, and platelet concentrates. He has over 100 index publications with close to 800 citations. He is a reviewer of several international journals of high repute and is on the editorial board of BMC Oral Health. He has a PhD in dental sciences with pioneering work on biomimetic textured GTR membranes. He has filed 2 patents, one of which has been granted, and has contributed as a lead author in book chapters with Springer Nature and Elsevier publications. Dr. Satpathy is a practicing periodontal surgeon as in charge of the Integrated Department of Oral Implantology at the IDS SOA University, Bhubaneswar, Odisha.
Dr. Purnima Nadkarni, ma'am, to kindly introduce the speaker for the session, Dr. T.V. Narayan, sir. Kishore, Dr. T.V. Narayan's introductory slide, please.
Good evening, everyone. Thank you for having me here. And it's my privilege to introduce our speaker, Professor Dr. T.V. Narayan, sir, who is an MDS in Oral and Maxillofacial Pathology. He is the ex-professor and head of Oral and Maxillofacial Pathology at the Oxford Dental College, Bangalore. He has a private practice of multidisciplinary dentistry since 1997 and is a fellow and diplomat of the ICOI. He is the co-founder and co-director of the ITI Study Club Bengaluru from 2012 to 2017, and he's on the editorial board of Quintessence India Journal. He's an expert on Dental XP and Premier Outline Dental Education Portal. He's a faculty on DACE, DACE and Dental XP's MOI course. He has published over 40 scientific papers in national and international journals on both pathology and implantology, and has authored chapters in the book titled Partial Extraction Therapy in Implant Dentistry. He's a part of the global research group for partial extraction therapies and has lectured widely at national and international conferences on pathology and implant dentistry. Welcome, sir. Please join me in welcoming Professor T.V. Narayan, sir.
Dr. Narayan?
Can you hear me now?
Yes, please.
All right. I'd like to share my slides. Yeah. First of all, thank you so much, DIOH and Dr. Sangeeta for this invitation. I mean, and it's been really an enriching, experience sitting here and listening to Dr. Anuj and Dr. Balaji Manohar. I think they were outstanding presentations. It actually makes my job easier and harder to try to because there was one which was like an overview, and then there was one which was so heavily academic that it's a difficult act to follow through on. But let me try and do my best out here. What I've tried to do here is, having been an academician for 17 years, being in in university teaching for a long period of time, as well as being a private practitioner for so many years, doing all sorts of things, I've tried to put this together to make a clinically relevant presentation. So what I hope to kind of deliver here is something that that practitioners will be able to take back to their practices and apply in the days to come. As it has already been expressed ad nauseum now, we need to work in combination with the physicians. We cannot be nor can the physicians be blind to our requirements. So I think this is a great step in moving in that direction. There are a few learning objectives here. I'm going to try to talk a little bit about the pathogenesis of the complications that arise out of diabetes. What are the salivary disturbances? This is another unfortunate thing that Subra could not be here with us, and I wish he could have done this part because he's such a brilliant academician himself. I'll try to do justice to that part which he was supposed to do as much as I can. But I will try and talk to you about the disturbances that result from diabetes and anti-glycemic therapy on the salivary glands. Then the oral mucosal and tongue lesions which are associated with diabetes mellitus and anti-glycemic therapy, and the management of oral and mucosal and salivary disturbances that arise out of this. The thing is that it is very difficult to dissociate salivary disturbances from mucosal disturbances, from periodontal disturbances, from dental disturbances. They are all so interlinked to the whole process that it's just as well that we are able to put them all together in one umbrella. Under one umbrella, let's say. So just to put it all together, it is a complex of metabolic and hemodynamic Anuj expressed right in the beginning. So the three mechanisms, though hyperglycemia is the primary mechanism, but the primary definition or the primary clinical characteristic that we use to define diabetes mellitus, there is dyslipidemia and insulin resistance which come into play. So this very intertwined kind of interaction is what leads to all the complications that take place at a cellular level, and therefore after that at a macroscopic level that we get to see in our in all these patients that have chronic diabetes or chronic complications from diabetes. Most of the complications that we talk about are chronic. So this interaction basically leads to an increase in reactive oxygen species, as Dr. Balaji already mentioned in his lecture, which will lead, along with inflammation and ischemia, leads to immune dysfunction and healing impairment. All of which together, if you put it all together, basically leads to a lot of cellular damage. What you end up with is intracellular glucose, which is not getting utilized. So on the one hand, you have hyperglycemia, and on the other hand, you have dyslipidemia. So if you have intracellular glucose, you increase the reactive oxygen species, and then gets into an upregulated pathway of GAPDH going into the AGEs and RAGE. So I'm not going to get into those molecular mechanisms so much, but the overall effect of this is going to be immune dysfunction, and there is going to be tissue damage, which eventually leads to our problems of periodontitis, caries, dry mouth, etc. Now, if you break this down into what goes on in disease progression itself, particularly in gestational diabetes, you may have the effect of the reproductive hormones and the vascular disease that takes place as a result of these interactions that we spoke of, which will lead to so we're not touching upon periodontal disease and gingivitis, etc., but it leads to that. The immune dysfunction that takes place again leads to all of these possible complications of diabetes, which include lichen planus and oral cancer and benign migratory glossitis. Again, candidiasis, angular cheilitis, dentist stomatitis, all of which are forms of candidiasis. Side effects of drugs that are again, like I said, there is so much of an interaction between disease process to the therapeutic process that at the end, it's very difficult to tell what caused what. So our job as clinicians is now to try to delineate strategies to make things work better for our patients, and making sure that the victories that we get out of therapy are not pyrrhic at the end of the whole session. So the other complication of the target cells, or the cells that get affected most, are the endothelial cells and the small nerve endings, the distal ends of nerve endings. Those are the ones that are most affected by the hyperglycemia that diabetics have. So what is the effect? So it's just easier to try to imagine that the effects of the disease itself will be felt more on structures that are heavily vascularized and structures that are heavily innervated. So you have, on the one hand, the kidneys, which is again heavily vascularized. You have the retina, which is heavily you have nephropathies and retinopathies. In a similar manner, the oral cavity and oral tissues are so heavily vascularized and heavily innervated that it is but natural for us to expect similar mechanisms to affect the oral cavity as well. So let's break it down from salivary gland changes. What happens in salivary glands? And it all starts with of course, like I said, this is chronic, right? The disease process is chronic. So when the disease of diabetes has set into a point where there is neuroregulation, the autonomic neuroregulation of salivary glands is altered, you end up with a microvascular disease and myoepithelial cell atrophy. Now, these myoepithelial cells are responsible for actually expressing saliva out of the salivary glands. So at this point, when all of this is happening, you have an accumulation of fat and a paradoxical acinar hypertrophy. It's like a compensatory mechanism. You are trying to have more cells or larger cells trying to push or produce more saliva to push it out. Unfortunately, the cells that are going to help express the saliva are not going to be functional anymore because the myoepithelial cells have undergone some atrophy, and therefore you end up with impaired secretions. If you have impaired salivary secretion, it impacts everything in the mouth. You end up you do not have any kind of lubrication. You don't have the the defense systems that saliva has in terms of the immunoglobulins, as well as some cells and enzymes that would help to think the buffering action of saliva. All of these mechanisms that maintain homeostasis in the oral cavity are lost because you have impaired salivary secretion. Now, it is a very common finding in diabetics to find a non-neoplastic and a non-inflammatory enlargement of the salivary glands, which we know as sialidinosis. And according to most literature, this enlargement is between 10 and 48% of all diabetics. So it's very, very rampant among diabetics. That means that salivary impairment becomes the cornerstone of all the problems that arise out of diabetes mellitus and in the oral cavity particularly. You also end up with, like I said, impaired salivary flow. But apart from that, there is an alteration in composition. The alteration in composition is usually an increased amount of glucose in the saliva, the increased amount of total protein and potassium, and reduced salivary flow rates. All of these things together will again cause what we know as xerostomia. And if you take world literature, all English language literature put together, you find that about, there is 40 to 80% of diabetics are estimated to have xerostomia. Xerostomia on an absolute level to a relative level, but when you combine it with other things like dehydration, which could happen because of the polyuria that is associated with diabetes, which could happen because of anti-diabetic drugs like semaglutide or Ozempic, and then the SGLT2 inhibitors like Jardiance. All of these drugs also reduce salivary flow. In addition, you have patients who have neuropathy, and they are often given antidepressants to control neurologic pains. So if they are taking that, then again there is a reduction. So it doesn't end with the fact that the disease itself causes impairment of salivary function. It is compounded by the fact that we are adding medication, which could probably impact salivary flow itself. And caries of this nature in xerostomics, it's not at all unusual to find, be it in heavy diabetics or be it in patients with Sjogren's. You will end up seeing caries which is completely uncontrollable. Now, if you take the whole cycle of events that go on here, between the possibility of implant failure, to periodontal disease, to all of those things, and peri-implantitis, what are your options when you come to deal with patients like this? Are you going to be telling them, sorry, I have to just take your teeth out and consign you to wearing dentures when you are going to have a dry mouth for the rest of your life? Your dentures are going to rub against. So these are those crossroads that we will discuss a little later as we come across. The other thing that happens in these sort of patients who have such dry mouths is that they are much more prone to small traumatic abrasions and so on, which lead to very painful ulcerations in the mouth. So the mucosal disorders that come off that we come across in diabetes is a combination of these factors, starting with salivary hypofunction, which leads along with immune dysfunction and peripheral neuropathy, which could lead to oral mucosal lesions, which may be related to candida. Candida is very not spoken of enough and not focused on enough as far as management of diabetic complications in the oral cavity are concerned. And I've spent a little bit more time on candida related mucosal lesions, because I think we need to get that awareness across, not only to general physicians, but to more to dental practitioners themselves, because we don't spend enough time on trying to understand how this works. Apart from that, you have non-candidal oral mucosal lesions, and you have the burning mouth syndrome. So if you just do an overview of what are those oral mucosal lesions that are related to diabetes mellitus, you have oral candidiasis, fissure tongue, papillary atrophy, benign migratory glossitis. There is a condition known as the Ozempic tongue, right? Ozempic is now, even though we are not using Ozempic so much in India, it is something that there are. You have people coming from all over the world, and you come across patients who will come up with symptoms of Ozempic tongue, and it's necessary for us to be aware of that. You have lichen planus and lichenoid drug reactions, and oral cancers and burning mouth syndrome, and I'll touch upon some of these briefly. Let's start with candidiasis. Candidiasis has a prevalence of 15% in diabetes mellitus. That's 5 times as much more in diabetics versus non-diabetics. And its pathogenesis is, it's complex in the sense that you have the same mechanisms of hyperglycemia, dyslipidemia, and insulin resistance, which have led to the reduction in salivary flow, increase in salivary glucose, increase in pro-inflammatory components, and reduction in the anti-inflammatory agents that are there in saliva, and overall reduction in immune response. So when you look at this whole so why candida, which is so omnipresent in all our mouths, why is it so much more of a problem in a diabetic as opposed to a non-diabetic? The answers are right there, because candidiasis is an opportunistic infection. It's a commensal as long as the conditions are right. But once the conditions are in favor of candida becoming more proliferant in the oral cavity, it turns into an infectious process, and now it's a very difficult infection to handle. Please, let's not. It's a very different thing from a small bacterial abscess or something of that nature, which you lance, you give a course of antibiotics, and this is chronic. It has the adhesion mechanism of candida is so strong that it's very difficult for you to dislodge it. So antifungal therapies they don't take care of candida so easily unless there is a very concerted effort in also keeping the hyperglycemia down. So overall, the prevalence of candida-related lesions is far more in diabetes mellitus than in others. And the clinical types are pseudomembranous, denture stomatitis. We'll just put it under that large umbrella over here. But I think, so again, the same conundrum that you have. Many of these patients who have had diabetes for a long period of time have lost teeth and have not been advised implants because it is assumed that implants will fail, or have not taken the risk on their own risk, and have eventually ended up with dentures. Now they are also hyperglycemic. They have so the prevalence of candida, the actual presence of a denture makes it much more conducive for candidiasis to take footing in the oral cavity. And then there are the more minor of these events like the angular cheilitis and median rhomboid glossitis. So let's take a look at denture stomatitis, pseudomembranous candidiasis, and then denture stomatitis. So the typical appearance is like this curd, scrapable white lesion, which just comes off very easily. leaves behind an erythematous base, and you have a typical complaint from a patient of burning. That's the typical complaint that a patient will give you. Now, when you wipe off this thing, this white pseudomembrane, if it just leaves that erythematous surface but does not take away mucosa, then then you're dealing with pseudomembranous candidiasis, and you can now treat it as candidiasis. But there are many conditions that would masquerade as this. And when you wipe off this pseudomembrane and you find underneath that for instance, like in the picture on the left hand side, you actually strip away epithelium. This is what we know as Nikolsky's sign, and this would be some other condition like a pemphigus vulgaris, or a drug reaction, or an erosive lichen planus, like the tongue lesion that you see on the right hand side. So these now need to be treated differently. So it's imperative that we make the diagnosis right at in the first place. And what are the ways to establish diagnosis? And I still remember Dr. Shetty, who used to always tell me that you will find candida everywhere. You'll find candida in all these three lesions, right? So just the mere finding of candidal hyphae, or the mere finding of yeast forms, or unless you find both forms, in which case it is candida. But just finding candidal hyphae or pseudohyphae does not establish it as a thing you should be able to culture. Or the best measure of making the diagnosis is that it responds to antifungal therapy. All right. And if you do not make that distinction right in the beginning, that this is possibly candida or this is something else, then your whole track of treatment is different, and you end up probably actually causing a lot more damage by giving antifungal therapy to someone who's got an erosive condition of that nature. Denture stomatitis, on the other hand, is very closely related to the fact that there is a person wearing a denture. There's no, I mean, the name says it all. And it's actually been graded by Newton, and it's graded way back in the 60s, where type 1 is just a localized inflammation. Type 2 is a generalized erythema, which covers the entire denture bearing area. And type 3 is inflammatory hyperplasia. So basically, depending on severity of the disease. Now, why do you get denture stomatitis? What is the relationship between, I mean, why do you get more candidal infection? It's purely candida, right? Why do you get more candidal infection in patients who wear dentures? First of all, it's the porosity of the material that we use itself. Polymethyl methacrylate has a lot of porosity, which is the most common denture-based material that we have. The dimorphic forms of Candida species have a very high adherence to PMMA, right? Along with other species of bacteria. So the biofilm is not only Candida, it's a mixture, it's a combination of these fungi along with other species of bacteria. Now, the bigger problem is that denture hygiene is not very well taught and not very well practiced, as is dental hygiene, right? We all know that our patients are not, I mean, dental hygiene is the last thing on their mind, as is denture hygiene. You will see patients with dentures with material that looks like it's caked over there for centuries. But if we do not educate people on how to keep their dentures clean, you are going to end up with a much more complex pathogenic biofilm on it, which has very tenacious adherence. And it's very resistant to host defense. It's very resistant to any disinfectants that you may use, which are immersion disinfectants, and any other antimicrobials. So when you have this in combination with the fact that your salivary flow is reduced, your immune surveillance, etc., has also been reduced in diabetics, the higher susceptibility for Candida and denture stomatitis is just evident then. And this is typically what you would see in patients who do not keep their dentures clean. You see a lot of, debris on it. It may be an ill-fitting denture, in which case what you do when you do a pap smear of that, you will find both you'll find a dimorphic form of both a yeast as well as a hyphal element uh, of candida there. So how do you manage this? First thing is improve denture hygiene. That means educate your patient well, and most of the time, a good mechanical cleaning using a brush that is designed to clean dentures on the intaglio side is good enough. Apart from that, you need to have you need to educate them about using immersion disinfection, which often is hypochlorite or EDTA based. If you have metal frameworks, use alkaline peroxides because hypochlorites will corrode your metal frameworks. Antifungal treatment for those which are more recalcitrant. Topically, you can use miconazole, you can use nystatin as a rinse, and fluconazole on a systemic level if it is required. And you have to educate your patient that dentures are not forever. Nothing is forever. I keep telling my patients, not even true love. So, you need to educate your patients that their dentures need to be maintained and replaced as you would do with the car or anything else, right? So you need to educate your patients about that. I have had a patient who wore one set of complete dentures for 29 years. She had worn it down to the denture base, but that was it. She was so happy with it. Uh, you have this other condition known as median rhomboid glossitis. The prevalence is said to be about 26% in about 26% of diabetics. It is much more in patients who have retinal and renal complications of diabetes. And so if you see a patient who is a diabetic and has a median rhomboid glossitis, it's incumbent on you to inform them to get to see their diabetologist to check if they have any retinal or renal complications. It's not the other way around, right? It's not always that the physician sends you the patient. You can also now take it upon yourself to tell them that with this particular finding, it's likely that you have more problems than you know. So why don't you go and get yourself checked? So this is one of those small but significant disorders in the oral mucosa, which may not have any symptoms at all. But if it does, you may have a burning sensation, and all you need is a topical antifungal. We used to see this, and we still see this in what we used to call the catnap syndrome. So a chronic atrophy or central atrophy of the tongue, along with the non-specific atrophy of the palate, what used to be known as the kissing lesion. So you see a similar in the same area, similar atrophy on the palate, where you do not find fungal hyphae. You do find fungal hyphae in the median rhomboid glossitis, and we used to see them mostly in BD smokers. And that's significant because they are also at a higher risk of oral squamous carcinoma. One very common finding in diabetics is the fissured tongue, and it's supposed to be 5 to 18% of diabetics. I mean, if you go do the cross section of all the papers that you can read on fissured tongue, as opposed to just 0.4% of non-diabetics, to maybe 3%. It's very likely because of the reduced salivary flow and then the subsequent susceptibility to trauma in diabetes mellitus. You have other conditions that you should exclude, including things like Melkeson-Rosenthal syndrome, psoriasis, and Sjogren's syndrome. Downs, you will know if you think, along with Melkeson-Rosenthal is actually a part of this big spectrum known as orofacial granulomatosis. On the other hand, you could have a complete atrophy, right? A total papillary atrophy, as you see in this case out here. And this was a 90-something-year-old gentleman who had been diabetic for more than 60 odd years of his life. But the biopsies were done just more to allay his fears than anything else. But just chronic diabetes had wiped his tongue clean and turned it into a properly bald tongue. You may also have angular cheilitis, and when you have a combination of a bald tongue and angular cheilitis, you must rule out other nutritional deficiencies, including the vitamin B complex, etc. Okay, then you have a common condition known as benign migratory glossitis, which again seems to be more common in diabetes than in others. And the pathogenesis of this and its relationship to diabetes is largely unknown. It may sometimes be symptomatic, having an itching or a burning sensation. It sometimes gets, I have seen it getting exacerbated by, consumption of certain foods like citrus fruits and so on. There may be an allergic or immunological component to this, which we are not very clear about. It is a psoriasiform lesion as far as the histopathology goes. So it has been associated with psoriasis and eczemas and arthritis in certain forms. What I mentioned before, the Ozempic tongue, is basically taste changes which are associated with the use of some. So taste changes occur because you have xerostomia, you have inflammation, all of these things bring about taste changes. But there is a very kind of specific taste change that happens with the use of this drug, which is getting more and more prevalent now. People are using it not only for diabetes, they're using it to lose weight. It's turning into one of those, and people are also waking up to the problems of Ozempic, and so it's losing its sheen a little bit. But you may come across patients who come to you from other parts of the world. I had a patient who I placed a few implants for, and so this is anecdotal, but it's relevant. A few days later, she came back and told me, doc, after you did the implants, my taste sensation has changed suddenly. Everything seems very sweet. I said, that's very nice of you to say that things are very sweet because I placed some implants, but unfortunately, I don't see a relationship between placing implants and changing your taste perception unless I injured your lingual nerve in some way. And then I dug a little into literature and I came across this condition, which actually makes people uh, feel an enhanced sense of sweetness to a lot of foods that they consume. And this is one of the side effects of semaglutide, which also has other side effects like xerostomia and dysphagia, by the way. So this is postulated that it is probably due to some altered gene expression of taste receptors. But most patients describe an enhanced sweetness. Some may describe a bitter or a metallic taste or a sour taste, but many patients describe an enhanced sweetness. So just remember that there is another condition walking around town. Lichen planus and lichenoid drug reactions. Again, very difficult to differentiate on a clinical level, on a histopathological level, especially when there is association. Now there's a lot of literature which says that lichen planus is more common in diabetics. Diabetes is so common, lichen planus is so common, it's very, very difficult to make. It's just an association. It's very difficult for us to put a cause and effect relationship on the other. But on the other hand, there is certainly a lot of lichenoid reaction that occurs because of anti-glycemic medication, and we'll discuss that in a minute. But one of the ways for you to differentiate lichen planus from lichenoid reactions clinically is that in lichen planus, classically, you will have bilateral lesions. You see bilateral cheek lesions with the, with, and lichenoid reactions often just show up on one side. You may not see the lacy pattern that you see of Vikram's striae on this. You do see this lacy pattern, but this is only a palatal lesion. There is nothing else anywhere, and this seemed like a drug reaction more than lichen planus clinically. And yeah, so when you look at, the trying to make a relationship between these two, uh, between lichen planus and the diabetes mellitus, this association seems to have very contradictory findings, and you have to, consider very diverse factors when studying this association to understand its results properly. Diabetes has a high prevalence, and you need to, I mean, both of these diseases are so highly prevalent that it's very difficult for you to say that one occurs because of the other. But all of these, anti-glycemics, that is metformin, glibenclamide, and gliptins, all of them are known to cause lichen, or to aggravate lichen planus, or to cause reactions that are lichenoid in nature. So when you come across lesions like this in diabetics, the first thing is to first establish whether it is indeed lichen planus or it is a lichenoid reaction. You're again at one of those crossroads on how to manage this, because typical management of lichen planus has traditionally been with corticosteroids. Now, in a patient who's a diabetic, giving a systemic steroid, you run the risk of the metabolic syndrome and causing a hyperglycemia. It's hyperglycemia over hyperglycemia. So, is this the right way to treat lichen planus? I find that topical tacrolimus, on the other hand, which is 0.1% weight by volume, and available now as an oral gel formulation, which is commercially called Taquido Forte, uh, is a far more satisfactory means of dealing with oral lichen planus without with much reduced risk. Tacrolimus also can be a hyperglycemic. It can also cause hyperglycemia, but taken systemically. 0.1% weight by volume, topical application, it's very, very unlikely to spike your blood glucose. Unlike steroid, even when applied, because steroid therapy, even though it is, even when it is on a topical level, where the number of applications per day, you need to have at least 4 applications a day. You need to have it for at least 3 weeks. Often the uptake is so much that you do end up with spikes in blood glucose. One therapy that I have found very promising in my practice is photodynamic therapy. I use a low-level laser at 660 nanometers with methylene blue as the photoactivator dye. That is the first application, and beyond that, it's usually only photobiomodulation by just running only the laser on the, I mean, without any contact, of course. But you see this lesion, and completely asymptomatic and down to just that much within a week after one single application of photodynamic therapy. And I found this not only in diabetics, in all other lichen planus patients. I found this to be of great benefit, and I embrace it because of the fact that there is really nothing that is going into the patient's mouth. They're not ingesting anything. There's no other side effect involved out here. So when available, I think this is probably a great way to go. We did hear about oral squamous carcinoma to start with, I mean, right in the beginning about the increased risk of oral squamous carcinoma. Yes, there is an increased risk of oral squamous carcinoma. There seems to be an association again with diabetes and oral squamous carcinoma. We seem to have more numbers of or a higher prevalence in diabetics, especially in women. And it's easy to try to understand why. You have hyperglycemia, you have inflammation, you have lost immune surveillance, you have xerostomia, which causes friction and trauma. So, now jagged teeth can turn into, carcinogens. Your oral hygiene is poor, and periodontitis a few years back. I mean, we did a paper on a large paper of, a large number of patients where we did just a survey on periodontitis and squamous carcinoma, and there's a very, very strong association between periodontitis and it makes sense. Both are, anaerobic processes, and both have, lot of microbial as well as immunologic similarities. And so we find that periodontitis, oral hygiene, and squamous carcinoma actually correlate very, very heavily. And in that, given that scenario, it is but easy to understand that oral squamous carcinoma is much more prevalent in these patients. We have also seen how much more candidiasis occurs in these patients, and we also know about the role of candida in the causation of oral squamous carcinoma. So given all this, and the fact that smoking and other tobacco habits and alcohol are as prevalent as they are, in a diabetic, it's not surprising that oral squamous carcinoma is much more prevalent. Uh, does this mean that you're, I mean, does it change much as far as you're concerned? Both are very common diseases. You're likely to see them, but you will, if you are not equipped to handle it yourself, your job is to act as the conductor of that orchestra and direct the patient into the right hands for that. And this was a squamous carcinoma, surprisingly, in relation to an implant in a diabetic who also had some lichen planus. So now tell me what caused this squamous carcinoma. There are those who will say, those titanium naysayers will say that it is the titanium, those who will say that lichen planus is pre-malignant, those that will say that it is the diabetes that caused it, and so on. So there's no way that you can differentiate one from the other. The last part of what I'm going to talk about is the burning mouth syndrome. And again, I've tried to analyze how this comes about. You have hyperglycemia, dyslipidemia, insulin resistance, and all of those problems that we spoke of right in the beginning with the reactive oxygen species and all those pathways of breakdown of glucose within the cell, which do not work anymore, right? So you don't have glycolysis, you've gone into the hexosamine shunt and so on. So now you are left with a problem. And one of the, like right in the beginning, I told you that apart from endothelial cells, the other thing that gets affected is the the distal nerve endings, right? The distal ends of or small nerve endings that we have. So that peripheral neuropathy that takes place, which manifests itself in the mouth as a burning mouth syndrome. But the problem with burning mouth syndrome is that, like, the problem with burning mouth is everything else can cause burning mouth. Lichen planus causes burning mouth. You have candidiasis, it causes burning mouth. You have xerostomia, you can have a burning mouth. So here you do not find any other physical cause for this burning mouth. There is no evident lesion. It's just that the patient complains of burning is one. They may have sensations of burning on the tongue. They may have sensations of an itch. They may have patients who come and say, my tongue itches on the side. They may have altered sensation. So it's all put together under the one collective term of burning mouth syndrome. it has a higher prevalence in diabetes than in any other condition, right? So this is the one condition where there are many more patients. So burning mouth can happen in patients who are alcoholics. It can happen in patients who have peripheral neuropathy for any other reason. I mean, in women who are postmenopausal or perimenopausal, they have burning mouth. So these are the other conditions where you may come across this. But the one condition where it's almost, the association is very strong is with diabetes mellitus. And patients who have peripheral neuropathy on the limbs uh, are more likely to have burning mouth syndrome. So it associates very closely with peripheral neuropathy in other parts of the body. You must rule out other concomitant pathologies, which also are common, like xerostomia, lichen planus, lichenoid drug reactions, denture stomatitis, etc. And when it comes down to management of this very difficult condition, you need to get very, very strict glycemic control. You need to monitor oral hygiene, uh, give them saliva substitutes, give them anesthetic mouth rinses. Capsaicin works as a counter irritant to an extent. Alpha lipoic acid as a supplement works. One of the best sources, especially in India, as being a vegetarian country, and I've had not a, I mean that's a myth, but a lot of people want to believe that they are vegetarian, so they are very averse to taking gelatin capsules and so on. One of the ways to get alpha lipoic acid is using spirulina, which is a really rich source of alpha lipoic acid, and it's plant based completely. And B complex and zinc supplements. These things, uh, if not on a therapeutic level, maybe on a placebo level, do help to control symptoms to a large extent. What do you do with your patient? I mean, do you have an algorithm in your offices on how to assess patients who come in with diabetes? And this is a simple questionnaire which will help you to see if they've got. This could be used by both dental practitioners as well as general practitioners or diabetologists to see if there are complications which need to be addressed by either or of the specialities, right? So you could ask them simple questions like trouble swallowing, trouble chewing, hyposecretion, whether your blade sticks to the mucosa, your tongue blade or your mirror sticks to the mucosa, pooling of saliva is not there, and so on. Are the glands enlarged? Just simple examinations. Fissured tongue, atrophic tongue surfaces, median rhomboid glossitis, etc., and whether there is any candidal infection, angular cheilitis, and so on. So a small questionnaire or a small data set like this goes a long way in helping you to understand what the complications that your patient is suffering. And in conclusion, I'd like to say that what it's already been stated well before me, but diabetes is a complex disease, multi-system effects and complications. We have also understood that it goes both ways. Oral hygiene, periodontal disease control does affect. In fact, the first article that I read about the insulin requirements in diabetics and periodontal disease control was published in 1964 by Murrah. That's that long ago. People knew about it. We never did much about it. So this is a great initiative for everybody to come together to try and do something about this. While hyperglycemia is the cornerstone, there are other intertwined processes, insulin resistance and hypertension, and immune dysfunction, which all get together to cause all these complications. While the most affected cells are endothelial cells, they also affect those nerve endings, and most of the disease effects are seen on vasculature and on and our neurologic effects, and that's what we come across. The fact that we are using a lot of drugs which can cause similar appearing similar symptomatology in these patients means that we have, it's a very intricate web to try to get through. So we need to start to stratify our diagnostic strategies to understand what we are dealing with, right? So I think that awareness between all practitioners in medicine and dentistry, and that ability to come together and like this to come together to understand better is a very important thing. And kudos to you all to for the step that you all have taken in doing this DIOH. Sangeeta, great job. Thank you.
Thank you so much, Dr. T.V. Narayanan. I think it was quite an exhaustive lecture. You took us so subtly from starting from how it is difficult to dissociate from these lesions which co-occur, and then you explained in detail about and emphasized the xerostomia, which is a very common occurrence in the diabetics. Thank you for pointing us out the need to identify and diagnose the oral lesions and the ulcerations, which should be a practice among the physicians, as it was emphasized again and again that we need physicians to be able to look into these lesions and also to identify. And then you took us to the dentures and the denture stomatitis, covering the tongue, the median rhomboid glossitis in detail, and the various medications which are now causing this hyperglycemia, and the conditions which we see. Then coming to the lichen planus and the lichenoid reactions, again telling us in detail about how to differentiate with that, the ways and modalities to treat that with photodynamic therapy and the photomodulations, which are the newer trends nowadays, and touching upon the oral carcinoma and the burning mouth syndrome. I think it was the entire package was so wide and exhaustive, and thank you for so much for covering it in such a wonderful and simplified manner. And it is the need of the hour that both the medical and the dental fraternity come together to understand, identify, recognize, and make aware. Thank you so much for.
Thank you so much. Thank you.
Dr. TV, I think I would say one line. Now that's called a signature presentation coming from an oral and maxillofacial pathologist. I wouldn't be wrong in saying that. Such a comprehensive coverage, and I think you're the best person to take it, justifying it across.
Thank you so much.
Now I would like to invite Dr. Sumida.
Thank you very much, sir. It's excellent, and I learned a lot. Thank you very much.
Thank you, sir.
Okay, now we are towards the end of the session. Dr. Sumida, kindly take the final leg of the webinar, please, forward.
Sure, ma'am. Can we have the slide of Dr. Gunjan Gupta?
Nandkishore, Dr. Gunjan Gupta ka slide, please.
I take this opportunity to introduce Dr. Gunjan Gupta, who is a professor and head at ITS Dental College, Greater Noida. She is Diabetes India Oral Health Group member. She has an academic and clinical background spanning over 12 years. Consultant periodontist at various clinics in Delhi and NCR. Also runs her own private practice by the name Smile by Design Dental Excellence. Conducts various workshops on implants, mucogingival surgeries, and lasers. Has numerous national and international publications to her credit. Life member of the Indian Society of Periodontics, Federation of Special Care Dentistry, and Indian Dental Association also. Serves as an assistant director in collaboration with the Federation of Special Care Dentistry, supporting initiatives such as the Special Olympics. Honored with Global Professional Award in the year 2022 for excellence contribution in periodontology. She has also keen interest in periodontal medicine, specifically diabetes and periodontics, and has got various dissertations conducted on this topic. Contributed as a content developer for JP Publishers.
Thank you so much, Sumida ma'am, for this introduction. A very good evening to all the respected seniors, speakers, and chairperson. It was indeed an amazing session with such informative deliberation on this topic. It's my honor to be a part of this webinar, and thank you so much, Sangeeta ma'am, for giving me this opportunity to give the closing remarks on such an important topic. Firstly, Dr. Anuj Maheshwari explained very comprehensively on all the possible pathophysiology concepts behind the oral complications of diabetes mellitus. On the other hand, Dr. Balaji Manohar very beautifully explained the complications related to tooth-supported structures and peri-implant diseases with a lot of supporting evidences. Again, very well described salivary gland dysfunctions and tongue abnormalities and many, many more in diabetic patients, along with various treatment modalities by Dr. Narayan. So thank you so much, all the speakers, for giving wonderful deliberations and increasing our knowledge in this aspect. So without taking much of time, I would like to summarize the presentation, the webinar, as like more than 90% of the population suffers from oral complications, patients who are having diabetes. Oral complications include periodontal diseases, dental caries, oral infections, salivary dysfunction, taste dysfunction, delayed wound healing, tongue abnormalities, halitosis, and lichen planus, and many more. And the possible reasons behind them could be high glucose in saliva, poor neutrophil function, neuropathy, decreased salivary flow, and small blood vessel damage contribute to the oral complications of individuals with uncontrolled diabetes mellitus. It has been seen that knowledge regarding oral complication is often inadequate among people with diabetes. Therefore, creating awareness is imperative in diabetic individuals about the relationship between diabetes and oral health. We as clinicians, we need to promote awareness and stress the importance of maintaining proper oral hygiene, taking preventive measures, early detection, and appropriate management of oral complications of these patients through a multidisciplinary and interdisciplinary approach. A very important thing, dental surgeons and physicians should shake hands together and interact effectively to provide the optimum care to maintain good oral health free of complications. And lastly, all the risk factors leading to diabetes and insulin resistance should be prevented and addressed, like sedentary lifestyles, obesity, lack of physical exercise, smoking, alcohol, and many more should be avoided, along with intake of foods with low glycemic index. Therefore, maintaining good oral hygiene with a healthy lifestyle would definitely help in beating diabetes and its oral complications. And last but not the least, prevention is better than cure. On this note, I would like to thank you, all of you, for such wonderful, wonderful lectures. Thank you so much.
Thank you, Dr. Gunjan, for summarizing the whole agenda. And with that, we'll take leave from this fora till we meet again. And thank you so much, all the speakers, the chairpersons, for being and contributing a part of this webinar. Till we meet next, say bye. And we'll be sharing the token of appreciation as a certificate from DIOH, and we'll be sending across to all of you. So thank you now, and
thank you.
good
Bye-bye.
night. Take care.
Thank you. Bye-bye. Good night.
Bye. Good night.
Thank you. Good night. Bye.
Bye-bye. Good.
Good night, everyone.